Recording in progress. How about now?
Brian, how are you today?
Hey, Stephen. I'm great. How are you? Thanks for joining. Can you see me okay? I was just told that there's a camera problem.
See, I'm not hearing you. Let's see what's going on.
Okay. Looks like we've got about a minute to go. And I see that we have 9 participants. We'll just wait another minute. I don't believe that many have their cameras turned on at this point. We're stuck looking at each other's ugly mugs.
Hey, all right, I got my sound up now.
Okay. How are things in Brunswick?
They're doing good. I've actually been in Appleton County all week. Got through with our jury trial last night about 6:30. And so it was scheduled to be a 2-day, but we made it one long day. We started early yesterday morning. And so it always works good to get it done.
Absolutely. I know people appreciate that. All right, I'm showing that it's 2:00. I see that we have 10 participants on the call. Looks like we have Judge Kelly here, who's a member of the committee. We have Judge Hargrove, I believe, is also with us.
Yes, good afternoon.
Good afternoon. Thank you for being here. We also have Nora Haynes with us.
Hey.
Hey, Nora. We have Dr. Karen Bailey with us as well. Dr. Bailey, can you hear me?
I can. Sorry.
Great. Thank you. And we also have myself. So we have a quorum. I know that Dr. White has indicated that he would be here soon. There he is. Dr. White, can you hear us and see us?
Yes, hello.
Thank you for being here with us. We really appreciate it. All right, why don't we just go ahead and get started? This is the Behavioral Health Reform and Innovation Commission Subcommittee on Involuntary Commitments. And it's September the 1st. This meeting is scheduled for 2 hours from 2 to 4 p.m. This meeting looks like it will not occupy the entirety of that time frame, so we may be able to get out a little bit early. I hope there's no strong objection to that. Our first presenters today will be from Accenture. We have John Kivashi and Jamie Jordan with us, who are going to talk about the Stage 0 intercept study that I think has the possibility of really being a game changer. And I'm anxious to hear what the subcommittee members' questions might be and what they think about the possibility of further exploring the efficacy of some of the programming at Stage 0. Also, after we hear from our friends at Accenture, we're going to hear from Fiona Hall and Deborah Moses, and they'll be speaking about 1013 patients in Georgia emergency departments, in particular Piedmont Healthcare's experience. And I really look forward to their presentation. I'm thankful that they're willing to join us as well. I wanted to, just as a housekeeping matter, tell folks that they should have received copies of the presentations from both Accenture and also from Piedmont. They are included with your Zoom invitation along with a copy of the agenda. If you didn't receive them or are having difficulty accessing them, I also had Lynn send them out to you separately by separate email. So hopefully everybody has what they need in that regard. And of course, people who are attending through the public access lane, if they should desire to have any of these materials, they should reach out and we would be happy to provide them. Look forward to providing them and appreciate their interest. Let's go ahead and get started. Do we have John Key? Ms. Vashi, are you with us?
Yes, I'm here. Sorry, trouble with the mute button. Do you want me to share my screen, Judge Amaro?
Yes, and we have Ashley Dixon, who's also with us. She's our co-host. I think that she said that only one person can have their screen shared at a time. So you have the floor at present.
All right, so then I should, should I be sharing my screen or should Ashley be?
You should be.
Okay, I will do that right now then. All right, can everyone see my screen?
Yes, ma'am.
All right. Well, thank you all so much. I'm John Kivashi with Accenture, and I'll be explaining and going through the Stage 0 intercept study in Georgia that we are proposing. So we spoke with Judge Amaro, and a big issue in Georgia and just other states in general are adults with mental and substance use disorders going through the criminal justice system, and a majority of those individuals being identified through 911 calls or with law enforcement. Hence, SAMHSA at the federal level made this model called SIM, the Sequential Intercept Model, which basically goes through a framework of how individuals with mental and substance use disorders come into contact with and move through the criminal justice system, and who are kind of the stakeholders involved in that. So what we are proposing is we want to focus and explore how Georgia can be more proactive than reactive at this initial intercept zero phase right here. Which is when people can connect to treatment at the community level rather than arrest with law enforcement. So this issue is obviously a very broad topic. So we have narrowed it down to wanting to answer 3 questions. So how to help Georgian adults with mental and substance use disorders before the point of crisis and the call to 911, how to support Georgian communities before Intercept 1 at that Intercept 0 stage, and thirdly, are Georgia's Intercept 0 programs and interventions effective and robust enough through the whole continuum of care? And effective, by that we mean a measure of that could be looking at the return on public investment in these services. So this table here is just showing it's not exhaustive at all. It's a very preliminary look at example Intercept 0 interventions in Georgia. So some examples are, we have crisis lines. So obviously now we have the new 988. We have NAMI in Georgia as well. There are mobile crisis teams such as GCAL, that's 24/7. There are law enforcement friendly crisis services. More recently, we had the Georgia Behavioral Health and Peace Officer Co-Responder Act. There are also respite centers through DBHDD, and there are also substance use focused early diversion strategies through DBHDD. So again, this is not exhaustive, but just some considerations. 988 is still very new. We at the time right now don't have GCAL data to look through. The statewide co-responder program is also new. The DBHDD respite centers, there's only 5 currently across Georgia. And similarly with the substance use data, we would need to get that from DBHDD as well, because whatever was posted on SAMHSA site was pretty outdated. So these are just, again, preliminary looks at what Intercept 0 looks like in Georgia. And what we want to propose is, and what I'll cover now is moving forward, what we would like to look at. Next page. So if we want to answer those 3 questions that I laid out earlier, then here's an approach of how to do so. So first, we would want to learn and have a more exhaustive list of what Intercept 0 interventions are being provided, gather and analyze data from participating agencies like DBHDD, GCAL, NAMI, on who is being lost, who's being bounced around in the continuum of care. We then want to bring those identified stakeholders that coordinate care and programs and services in Intercept 0 to the table and learn from them on their current state, how they're doing program evaluation, and what the future could look like if everyone was aligned, coordinated, and standardly working towards similar outcomes, which would then help us determine the ROI of these Intercept 0 programs and seeing how effective they are, what their gaps in service, if there are any gaps in services in Georgia that we could provide, or how we could course correct. All this would be packaged in an action plan. And again, all around the intent of helping Georgians with mental and substance use disorders get treatment, and ideally not in the criminal justice system. So I have this timetable here, and I put some asterisks there. There's a big caveat that we obviously would want to make sure that the stakeholders and the agencies that we're identifying are willing participants to work with us to provide de-identified data. So that's why you see some of these asterisk marks here on the timetables. And we've actually done something similar, just to give an example of what we mean by ROI, or what we mean by this program is effective. So a few years back, for vocational rehabilitation services in Georgia, we worked with the agency here, where GVRA gave us de-identified aggregated data that we were able to analyze and determine how effective those programs were in giving jobs to people with disabilities, and how much money the state saved by those individuals not being on state-funded assistance programs. So again, this was a big success in terms of showing how programs are effective and how they're helping Georgians. So this is a similar model that we would want to do, but obviously with this particular topic, it would involve a lot of different types of stakeholders. So again, that's the kind of big caveat that I want to throw out there for consideration. So that's really all I wanted to cover. Judge Amira, was there anything else you wanted to add with regards to the intent or purpose of the study, or anything I missed? I'll go back a couple slides too.
So when you talk about this Intercept Zero evaluation and study, do you think that it's possible to determine which of the interventions we have at Intercept Zero would stem the flow of people into the criminal justice system, either individually or in groups? We can kind of evaluate their strength or weakness based upon whether or not they're stabilizing people 3 months, 6 months, preventing them from getting pushed further into the criminal justice system. Do you think that there's a way that each of these individual interventions, you mentioned a couple of them, but there's so many. I mean, if you take a look back at the presentation that was made back at the very beginning, December the 16th, I think it was 2019, there was a presentation by the Association of, just give me a moment here, the Georgia Association of Community Service Boards, and they provided in their presentation a service delivery continuum of care, which showed transportation, pharmacy and medication maintenance, traditional outpatient therapy, HIV support and education, community support, individual access and therapy, assessment and therapy in corrections and judicial, homeless services, community support teams, forensic day housing and treatment, shelter plus care, residential for homeless, semi-independent housing, mobile crisis in emergency rooms, mobile crisis in community. All of these types of programs set forth by cost and whether or not, and by acuity level. And that's just half of them that are on the sheet of paper. Is there a way that through the study that you're proposing that we can evaluate these types of services to determine what happens to people when they touch these services, and do they go in and touch other services, and how can these other services, or how can we evaluate the effectiveness of each of these programs? Is there, by their effectiveness in preventing people from going into the criminal justice system? I know that I'm rambling just a little bit, and I apologize for that, but trying to organize a thought here. I think that the thought is, I want to be sure that we can take a look at all of these interventions and programs and determine which of them are preventing people from flowing into the criminal justice system individually or in groups. Do you think that's something that can be done in a study like this?
Yes, yeah, I definitely think so. I think that first phase is going to be key. The first two phases really is going to be key in terms of identifying all these interventions, which, seems like you already have that list. But then also the bigger point would be reaching out and learning and working with each of the stakeholders to make sure that they understand the intent of this study. It's not, us coming in and, trying to tell them that their program is not working or, all their work is for nothing. But really just for more the greater good of seeing, where we all could work standardly together, and also what are the standard outcomes that we're trying to achieve.
Do you expect that there would be some need for some data analysis? For instance, when we get to the point where we're trying to identify the data will help us to evaluate each of these programs,
Right.
Which of the, how would you propose that we approach that? It appears to me that we need de-identified data, as you've mentioned, but we also need patient level data. So what are your thoughts about how we approach that patient level data and acquiring that without violating HIPAA?
Right. There are guidelines called Safe Harbor, where basically if someone that is a HIPAA entity, that they're able to follow these guidelines, where they're able to give us the data, but we're never able to actually pinpoint that particular individual. So I've been able to work with other groups as well in terms of gathering just aggregated data. So just basically a cluster of these are number of individuals in this particular region or this particular zip code, but there's no way for me to ever pinpoint that it's like this particular, Joe Smith.
Well, we understand that that's what the de-identified means, right?
Right.
And do you think that billing records would help us, or claims data would help us that the Department of Behavioral Health might have?
Yeah, if that's the data, if those are the data points that they use, then yes.
Do you think, have you ever done anything like this in any other state?
Not in this particular instance. The example I have right now is more using what we did in another Georgia agency.
And this is a bit of an industrial engineering approach, is it not?
Yes.
Trying to see how somebody enters the system and
right.
And how they bounce around, and what services they use, what services they don't use, what happens to them. Is that essentially what you're talking about?
Right. It's almost, if I had to give the analogy of like, kind of looking at the plumbing system.
Okay. And so are you familiar with any other studies such as this that have been done in any other state?
I have not. I'm personally, I'm not aware of any other type of state that's doing this type of study.
Okay. Does anyone else have any questions for her?
I just have a comment. This is Nora. So the sequential intercept mostly deals with the criminal justice system, correct?
Yes.
So for our committee, involuntary treatment, how possible would it be to add hospitalization in one of the intercepts?
Meaning, oh, I see. So instead of, if we're looking at intercept zero interventions, instead of looking specifically at going into the criminal justice system, you're looking at how do we help people before they even go to the hospital.
Right. Or even homelessness, because, our committee obviously doesn't deal just in the criminal justice system. We, have people going into probate court, into hospitals, and homelessness. And those, I don't know, I wouldn't even know, Judge Amaro, you might know, I don't know whether the numbers are larger going in the criminal justice system or whether they're larger going into the hospital or homeless system. I don't know, but all of those people are the ones that we're trying to help to keep from going into the deep ends.
I would foresee a study like this looking at how people interact with the crisis stabilization unit, the crisis intervention services like intensive outpatient programs, intensive residential women's services, sort of community treatment. psychosocial rehabilitation, peer support, peer recovery, supportive employment. All of these, what I would consider to be touch points. So when somebody uses one of those services, then they get some sort of a de-identified number, and then they would flow through the system on the adult mental health side, and then they would also flow through the system on the criminal side. We'd be able to watch how they interact, where they flow. Do they start with crisis stabilization unit, and 3 months later they end up in jail? And then when they're released on jail, then do they go back into the DBHDD care in some form or fashion and utilize some other service that they offer? And to what extent, for instance, have people who have been hospitalized by involuntary commitment, for example, also end up in the criminal justice system either 6 months later or 6 months before? What is the trajectory that these people are taking when they interact in the adult mental health system and the criminal justice system? Because I think that underlying this analysis would be the assumption, true or not, and this is something we'd have to evaluate, that we have a lot of people who are involved in both systems, and the systems don't know that they're involved in both systems. So we want to create this flow on both sides, on the adult mental health side and on the criminal justice side. And the SIM covers the criminal justice side, but we could have like a reverse SIM. We could have the SIM going backward into the adult mental health side that looks at every intervention on the adult mental health side, including hospitalization, to your point, Nora. And those interventions we could be following people along those axes as well, and then trying to figure out what works, what doesn't work. And so we would have to, it all starts with the data. All starts with being able to see someone when they come into a crisis stabilization unit, and then follow them for some period of time. We could also look backwards. Another way of doing this, and John, if you disagree, you can tell me, is that you could take a look, for instance, of all of the people who are in mental health courts, in drug courts, in veterans courts, and then you could ask them that they're willing to participate in a study such as this, where we evaluate their records and we see where they have been on the adult mental health side. And we see the kinds of services that they have been a part of over the course of the previous 12 months or 24 months. And it tells us something about the trajectory into the criminal justice system. So what I'm thinking is simply expanding Intercept Zero to see the flow of people who end up in the criminal justice system on the adult mental health side. So this is sort of the thinking that's going behind the idea of following people before they get into the criminal justice system. You can either do it by watching someone come in and then following them going forward, or you can do what I would call an autopsy. When they're already in the criminal justice system, you can start to look at their records and you can look backwards and ask them all about their interactions with DBHDD and with community service boards and the services offered by community service boards. And then you can learn something, hopefully, about how you can stem the flow into the criminal justice by looking backward at their files, if they're consenting to participate in that way. I don't know if that makes much sense, but do you follow me, Nora?
No, yeah. Oh, sorry, go ahead.
Yeah, for me, like I said, our job as a committee is to not have to involuntary anybody.
Correct.
Anytime. So that's what we're looking at. We do not want to force anybody into treatment, or that's what I feel. So in order to not do that, we've got to look at all the systems, not just the criminal justice system. So I don't know, have you ever done anything like that before with a sequential intercept?
No, we haven't. That isn't to say, we've done it in other use cases, but not in this particular use case. But I do like the idea that you're talking about, Judge Amira, about kind of more working our approach, instead of starting from Intercept Zero, going to Intercept One, is looking backwards at looking at Intercept One and how that touches Intercept Zero. I guess, again, my only caveat is, again, I would go with who would be willing and who we have the relationships with to do a study like this.
Well, let me just give you an example. I just had a conversation with Brenda Weaver, who is also on one of the other committees that are connected to this space. And it seems to me that, and also Stephanie Lopez Howard and Dr. Kevin Baldwin, the value in this appears to be in trying to identify people and who are in the adult mental health system and determine their path. I can't really distill it any more than that. That's the purpose of it. What is the path of someone who enters the adult mental health system over the course of from the beginning until the time that they end up in the criminal justice? What is it? What's the path for 12 months? What interventions do they touch? What interventions don't they touch? And what does that teach us about what we can do better? So I'll stop talking about that. I know that I've repeated myself a couple of times, and I want to apologize to the people who are listening if they can only see the top of my head. We're having a bit of a problem with the camera angle, but that's just the way it is. John Key, do you see that the committee is focused on trying to prevent people from being involuntarily committed?
Right. Yes.
And we're trying to prevent people from being incarcerated. And we want to evaluate these early services to determine how we can better organize them or mix them in order to avoid this flow into the system.
No, that makes complete sense. And feel free to let me know if for you, Judge Amaro, would it be best if we kind of go back and give this other more different type of approach, or kind of redefine our questions around the feedback that we just got to give back to you?
Well, for sure. But at the very least, I would think that we have to identify all of the adult mental health continuum of care offerings.
Mm-hmm.
And then start with that. And then look at the ones that address low acuity versus high acuity. And then look at the relative costs of these approaches, and then see how many people each of these interventions touch.
Right.
And are they the same people, or are they, you started to see what I'm thinking about there?
Right.
And I think that's what Nora's thinking about too. Does anybody else have any different conception of something like this?
I would just need to add that many of the encounters within law enforcement and also within mental health clinics, hospitals, et cetera, have to deal with individuals that also have substance use disorders. And so we would need to make sure that we exhaust a list of various resources that we have across the state or lack of, and how that may be kind of fueling through these other channels. So some of these numbers may be skewed without that data.
Okay. All right. Well, listen, thank you so much, John Key, for your work on this. And if no other committee member has any additional questions, this is sort of the type of analysis that we're proposing, perhaps a grant program that people could compete for to provide some research services in this space. And thank you so much for your time.
No, of course. Thank you all for the feedback. And again, thank you for all you do. And yeah, we will go back and update. And Judge Amaro, I'll get back with you probably after the long weekend.
Okay, thank you so much. Let's shift now, if we can, over to the folks from Piedmont who will give us their presentations.
Hello, thank you. Can you hear me?
You're a little bit distorted, Fiona.
Okay, let's see if I can move the camera clip on. Is that better?
But we can see your whole head, unlike the situation with me, so that's good.
I wanted to give a second to introduce some people in the room. I think for Piedmont, we had a couple of technical difficulties.
we're still not able to hear. You're echoing way too much.
Well, okay, just 1 second. I'm just trying to log.
While Ms. Hall is working on that, let me just take a very brief opportunity just to share with the group a couple of other interesting conversations that are happening in view of some of our previous work. As I mentioned previously, we were talking about how I had just recently spoken to Brenda Weaver, and she indicated to me, she's with the Council of Accountability Court Judges, has been for years and years. And we're talking about how we could use psychiatric advance directives in accountability courts to allow for accountability court participants to direct their own care when they lack capacity. And perhaps we could use this new tool to have people in mental health courts and drug courts, and veterans courts, direct their own care through understanding and consenting to the entering into these psychiatric advance directives. And then there's this great program that Nora has, this ODR program, where the GCIC is used to allow police officers in an encounter with a severe and persistent mentally ill person to reflect that that person is in an ODR program, an Open Doors to Recovery program, and that this is a case manager number that they can call, a community navigator number that they can call. Well, I mean, wouldn't it be great if we had all of our accountability court participants treated in a similar way across the state? And there is such a rich pool of people that we can help that way. And so the folks over at the Accountability Court Council that I spoke to recently thought there might be some potential in that. And so I just wanted to share with the group that that's something that has been happening in the background this past week. And does anyone have any questions or thoughts about that?
I think it's a great idea. I mean, you know, apparently when we had our presentation a couple of weeks ago, it wasn't a big deal for GCIC on their end. So it's just obviously having people available for the law enforcement to call, right?
Yeah, well, it's having them, but you know, it's a several ideas coming together. It's the idea of having a person to call in GCIC, but then also having a psychiatric advance directive that allows the person who lacks capacity to direct their care beyond just a person to call. And so the coming together of all of these, along with the co-responder model that we're seeing that David Sweat's put so much time and effort into, these things can kind of come together in a way that's unique and special and really helpful to the people that are most vulnerable if we kind of come up with a plan that makes it work. Stephen, can you see how that could happen?
Oh, yeah.
One of the problems with using the GCIC system is you cannot be on GCIC unless you've had some sort of a criminal intervention.
Mm-hmm.
And also they have to consent.
Well, that's of course would be the case. And we'd have to give them a full autonomy and ability to withdraw that consent at any time. True. Wouldn't you agree, Nora?
Yeah. So the GCIC is great, but we might want to try to think about another database too. Because,
like a repository.
Yeah, like I can't think of the name of it off the top of my, what's the 24/7? What is it? 988?
988.
Because people that are in the GCIC are in the criminal justice system. So there are plenty of seriously and persistently mentally ill people that interface that are not in the criminal justice system. So just think about that.
well, maybe there's ways that we can approach that. And I look forward to any recommendations you might have. Fiona, do we have you there?
Yeah, can you hear me now? Is this better?
Much
That's
better.
much better.
Okay, perfect. So I want to just go ahead and let some others in the room introduce themselves.
Hi, Judge Amaro and committee. This is Deborah Moses.
Hey, Deborah.
Glad to be with you today. Fiona is the subject matter expert here, so I'm here to provide support and happy to answer any questions if I can along the way, but I'm going to defer to her today. Thank you.
And we also do, I see on the other line, we do have Steve Porter. He is also with Piedmont. He is our Executive Director for Behavioral Health Services and supporting the Piedmont effort for this service line. So I just want to acknowledge that he is also on the phone from Piedmont.
Welcome.
Thank you. I'm going to see if I can share my screen. Can you see that? Is it working?
It is.
Perfect. Something's working. That's awesome. So thank you guys so much for having us here today. We are presenting behavioral health, the emergency department kind of situation on our medical floors that we're dealing with here at Piedmont. My name is Fiona Hall. I have been doing behavioral health in the state of Georgia for over 18 years. I am a licensed professional counselor and have worked in the administrative capacity at different acute centers, inpatient facilities, and now have moved into Piedmont Healthcare to help them with behavioral health as a service and reaching out and seeing how we can better partner with inpatient services as well as our community services for the need of our behavioral health and mental health patients within our facilities at this point. So this main presentation is to talk about our emergency departments have really become the central intake point for patients who need transport to emergency receiving facilities. Due to our lack of available beds for evaluations and treatment, our patients are commonly held for days to weeks in our EDs, waiting for appropriate placements. This result delays necessary care for those patients and it impairs our hospital's ability to take care of other patients in need, as at times our behavioral health patients can take up quite a large number of ED beds, emergency room beds, waiting for patients, which then obviously backs up the patients coming in for other needs at that point. So for behavioral health patients that are brought in through Piedmont emergency rooms, the majority of flow is coming from EMS and law enforcement. That is the largest amount of people bringing our patients into the emergency room. We do have the mobile crisis units that are now working through the state that are also dropping our patients off. We have family and friends of our patients that bring them in, as well as walk-ins. And we have our state and private mental health facilities that are also dropping patients off at the EDs. Over to the other side of the screen, it shows the amount of annual encounters for each one of our Piedmont facilities that we are actually seeing for ED encounters. So these are our patients that are coming in through the EDs for all of our Piedmont emergency rooms per facility, and how many are coming in for our primary diagnosis of behavioral health. So they're actually coming to us to say, I am here in crisis, I want to harm myself or I want to harm another person. This is how we counted the number of encounters we had annually last year in 2021. So it's a pretty significant number of patients that are flowing through our EDs on a daily basis. Just breaking down our average ED, that's an average of 4 patients a day coming in through a lot of our EDs, and can be up to 10, 12 patients a day in some of our larger facilities. And the patients are brought into our emergency departments for main reasons: medical clearance, needed for behavioral health placement. There is almost nowhere else our patients can be medically cleared for placement of inpatient. Our inpatient facilities as a whole, for the most part, do not handle any medical issues, and there's a lot of medical exemption before they can be placed in an inpatient psych bed. So they're looking for this medical clearance from our ED doctors before the patients can be placed. There's an inability to find placement at psych facilities. So a lot of our mobile crisis units or state facilities that have a walk-in program will bring them to us because there are no beds available and they cannot keep them in their care. So at the end of the day, they're looking for placement, but they cannot find it. So it will come to our EDs at that point to find a safe place to manage that patient until a bed is open. They're transporting an at-risk patient to the closest facility for psychiatric assessments. So these patients are very high acute, very violent patients, psychotic patients, patients that are having extreme behavioral issues, and they're very much a risk patient to be transporting that point. Law enforcement, EMS will normally look for closest ED to bring that patient to at that point, so that the patient they can get that patient some treatment immediately through that ED. So that is another large area of risk that's coming into the EDs. And then a patient not responding to treatment at a local mental health facility. So we do have a large number of patients that flow to us from other mental health facilities and inpatient psych centers for various reasons, but a main one is that the patient is not responding to treatment per psychiatric treatment. So those facilities will look to our medical centers at that point to start medical testing, to try to find other reasons why the patient may be having failing mental health issues, such as an older patient at some point can have a basic urinary tract infection, but if undiagnosed and untreated, that actually will look like psychosis. So a lot of times we'll have an elderly patient that flows into an inpatient psych facility. We are treating them with the regular psychiatric meds. It's not working. That patient will then be brought back to a medical facility and be asked to run medical testing to find out if there's something else wrong that's being missed. So that's kind of an influx in how our patients are brought to the ED. What are the reasons why they're actually bringing them to the EDs instead of bringing them to an actual psych inpatient facility? Also, we do know that the majority of inpatient psych facilities do not receive any patients from EMS, law enforcement, by any means. So EMS is instructed to only bring patients to certain places, as is law enforcement. So the majority of our freestanding psych facilities do not take any drop-off patients in that way. They have some walk-up capacity, but that's about it. So for the most part, that ED becomes that place where they walk in, get their assessment, and then we are handling those packets that go out to our inpatient psych facilities for treatment. And so our barriers to placement for behavioral mental health patients in our emergency departments are difficulty in assessing a patient for admission due to the patient's inability to participate. So we do have to assess all patients for 1013 criteria. We have to assess patients for the level of need and acuity, and the patient does need to be able to participate in that assessment for us to move them to care. So we do have our patients that refuse those assessments, are on PRN medication due to violent behaviors that cannot participate. So there's various reasons to even get the assessment done, which can be difficult at times with our patients. That means that patient is not eligible for placement and will sit in our emergency room until we can get them to do that. The medical exclusionary criteria that we give to our patients, that our patients do have, and this is a very large issue with our mental health patients, is they are failing in medical, their medical health is failing as they get older. This is definitely a population who has at times not taken care of themselves, have made poor decisions, have large addiction pasts. So as they start to get older, their bodies are failing at a little bit more of a rapid rate than a healthy patient that did not have to go through some of the struggles of behavioral health patients. So we tend to see, as they start to get older, there is a large amount of patients that are now hitting medical exclusionary criteria for inpatient psych. These patients are unable to have different oxygen levels. Their labs are out of whack. They've got diabetes. They've got really very unmanageable medical situation for an inpatient psych. They're going to be excluded, and there's absolutely no facility they can go to. So that will then become a emergency room patient that will then be moved to a medical floor, and we will have to treat them with their behavioral health need on a medical floor, which is also something that's just clinically not great for that patient. They're not actually getting the continuum of care that they would need from a mental health stance. And we do have patients refusing medications or treatment. And this then causes high acuity of those patients. So patients are able to refuse medications and they are able to refuse treatment. Those patients can be very violent and absolutely are causing harm to self and others. So they sit within our ED situation because really they are at risk, but they are refusing treatment. Our inpatient facilities are at capacity. This is a daily situation. We have the majority, if we bring 4 patients into an ED a day, most likely 1 to 2 patients would be moved within that day to a facility. The other patients will stay, and we will rack that up per day as it goes along. So if we keep back every 2 patients every day, bringing 4 more on top of that, we do get to the places in our EDs where we're sitting 16, 20 or more mental health patients in our emergency room beds. At that point, at times, our mental health patients can actually take over and are sitting in more beds of our emergency rooms, waiting a psychiatric placement that our medical patients are taking up in those emergency rooms. Our medical patients are then being treated in our waiting rooms, and it can get really very stressful and really difficult for the medical teams to be able to help the patients in general. And then our patients are denied due to inability to treat the patient condition. This is another large denial. So our patients that are come in consistently on our chronic mentally ill patients are all, for the most part, those patients will start to be denied by all of our inpatient psych facilities. They will say, this patient is no longer treatable. We've already tried to treat this patient. This is just a co-occurring issue. This patient is baseline. This is something we hear on a regular basis. A patient is at baseline, which means there is no treatment that they feel that they can give that patient, so they're going to pass over that patient for another patient. This patient is still a mental health patient. They still are meeting mental health criteria, but they will not be moved out of the ED, and we will have to work on their medication and their issues within that emergency room setting. And the last issue and our largest issue is obviously a lack of insurance. Our patients that are our indigent population, and even in most parts our Medicaid population, are very hard patients to move. I will say that our commercial payer patients move within a couple hours out of our ED setting, but our Medicaid and our indigent patients can sit for 2 to 3 days, if not longer, at weeks at times, due to their acuity issues. So for the most part, we definitely are seeing a lot of backup, and I just wanted to share a story of one of our patients that we are dealing with, that we have dealt with, that kind of gives you an idea of what this looks like. So we did have a female patient brought to RED by family. She was diagnosed with schizophrenia in her early 20s. The patient was refusing to eat. She was refusing to consume any liquids or food. It was actually part of her psychosis, part of her diagnosis, and she was very paranoid about eating or drinking. This part of her this was actually causing a lot of medical issues. Her labs were very much out of whack. She was refusing medication. She was really refusing everything. The hospital continued to intervene, giving her liquids, giving her fluids, trying to help her. We would get her stabilized, get labs up. She was denied by all psych facilities. Absolutely nobody would accept this patient. And so we just kept going through this with her in the ED, of her denying everything, medical failing again, medical interventions having to happen. And this is in an ED setting, and this is at a Piedmont hospital where there's not a psychiatrist. So at the end of the day, we are trying to work with this patient through a team of people that do not do mental health and really are not at the level to help such an acute patient with treatment. This is someone that this is kind of a patient that we see more than I would like to say that sits in this really medical issue. We did have another male patient that came to our unit and had a catheter. He did get admitted to the medical floor. We were able to provide medical assistance, but due to the fact that he had a catheter, he was never moved to behavioral health inpatient psych. He was denied at all psych facilities, and so at the end of the day, we tried, he was very difficult to find. He was sat for 30 plus days in our medical bed, where at this point he should have already been moved, gone into psych care, been able to get the psych treatment he needed and discharge out. But due to that catheter, it was really unable to move. I wanted to stop briefly and see if anyone had questions. There's kind of a lot of bulk in some of these slides, and I didn't want to move on if anyone had a question on this slide.
Dr. White, do you have any thoughts or questions for our presenter?
I will say that we at Grady Hospital have some similar kind of issues within the patient populations and trying to get them hospitalized, especially with medical exclusion criteria and catheterization, et cetera. And so none of this is surprising and falls in line with similar practices that we have.
I'd like to know what it is you think that we can do to help in this space.
So I'll go through that in another slide. So we do talk
Okay.
about some of the things that we are doing previously at Piedmont, and I know other facilities are doing this. So of course, as you're talking about Grady, that absolutely, this is something that Northside, Grady, WellStars, CHOA, we are all discussing on a daily basis that this is something happening across the medical facilities systems that we're dealing with. So moving on to the clinical environment for behavioral health, holding in emergency departments. This is something we are doing. The EDs are clearly not a suitable environment for holding our 1013 patient for an extended period of time. They are loud, they are very chaotic. This is somewhere we are dealing with heart attacks, strokes, car accidents, patients being brought in extreme crisis, and then we have behavioral health patients that typically need a very therapeutic environment. These kind of loud noises, alarms, bells, and whistles going off are very triggering for behavioral health patients. And so this then leads to more aggressive behaviors. Behavioral health patients definitely do act out with aggression and violence when they are scared. And this is a setting where it is really difficult for our patients to be able to find a calm, safe place. And so this is something that if they're exposed to this for a great amount of time, it's very worrisome on our end to be able to give these patients that therapeutic setting that they need. Piedmont has and other facilities have started to build behavioral health pods within their emergency rooms. So this is a very safe space that we are building for patients and within our EDs. It's removal of unnecessary objects. There are definitely safety protocols we put in place for our patients to come in here to reduce harm to self and others. And also, we do give a special attention to the ligature risks that are within these spaces and ensuring that our patients are the safest they can be. They were developed for short stays, not for long stays, which our patients even staying there for multiple days is becoming a long-term stay within an emergency room. So there's no outside access for our patients. And I always think to myself, if I could not go outside for a couple of days, that would make me feel terrible. So there is no outside access for patients. The bathrooms are shared, and they are not easily accessible for patients without staff assistance. So our patients do have to ask to go into the bathrooms. We have to be around them while they're in the bathrooms, as there is no way to keep a bathroom completely ligature free. We do have very limited activities for our patients in ED. So just like anyone else who's gone to an ED, you have the TV. But if you're sitting there for great lengths of time, that's all you have. That's pretty discouraging. But there are very limited access for activities because really this is an emergency room setting, and we have to be very careful with what we give patients. The environment is not therapeutic, and their patients are staying for multiple days. So really these patients are needing a crisis intervention. They are needing a inpatient psych facility that is full of therapeutic interventions we're doing on an hourly basis. We're giving them coping skills. We're having music therapies. We're doing group therapies. We're talking with them through their anxiety. We're helping them deal with the crisis that's occurring. So this is what is being delayed with these longer term stays. The other area to add to it is that these pods have a limited number of beds, but everybody flows into those beds that have behavioral health. So if you have a patient that is in there detoxing, they are usually very stressed out. Detox is a very painful process. It can be really difficult for people. And then you have a patient that's psychotic who's screaming and yelling and running up and down the pod hallway. This is something that really triggers our patients. A lot of violent behaviors can happen because they can't handle each other within these settings. They cannot stay in a bed. So medical facilities, everyone's used to the patients in the bed. Our patients are not. They get up, they walk around. They're medically able to walk around and pace. They like to pace. So at the end of the day, they're all on top. They do walk out in the hallways, and we see a lot of interactions that is very difficult. You have major depressive disorders with detox on top of schizophrenia and psychosis, and they're intermingling in a small space in the ED, which is just, if the process worked the way we intended it to, they would be in there for a couple hours and leaving. We would not see this overlap. Our Piedmont facility is are definitely hurting with these established spaces. We have very limited, some of them have no Piedmont pods at all. They don't have any room to place a safety pod. So they're kind of clearing a medical room that's being used, but the patient can easily leave that medical room. They can easily walk out. And so we initiate one-to-ones on those patients, but patients don't like one-to-ones a lot of that time. They feel very that someone's in their space. So it can be very hard to work with patients outside of a pod and give them that space. And also we have shorting staffing and challenges. High acute patients make it very difficult in the ED for staffing to sit on them. They want to leave, they are fighting, they're aggressive, and they are absolutely going after the staff. And it's really very difficult to keep a lot of these patients safe for these long-term times after they've been there for 2 to 3 days, highly psychotic. I mean, it's getting very difficult at that point. Even when our safety pods were developed, they were just not intended for this kind of use. And we're really seeing a lot of the pods being full. So there's many times I'll go in and find all of our behavioral health pod beds are at capacity, and I now have 3 to 5 patients outside in our medical beds. And with every single one of those patients, it takes one staff 24/7 to sit outside of that room due to the safety concerns of the patient inside that room. So then we start pulling our techs and our staff off of our medical patients to be sitting on the behavioral health patients to ensure we can keep them safe. So the patient's experience by payer status, this is something I get asked about a lot. Patient payer status is a significant root cause of the inability to transfer patients to necessary care and evaluation. The average length of stay for our patients with commercial insurance is 3 to 5 hours. We almost never even see them. They're in, and the facilities are picking them up very quickly. The average length of stay for our patients with a traditional Medicaid or a novel insurance are over 2 or more days in our emergency room departments. There's almost no way that you're going to get a non-indigent patient to come in and move them out of the ED within a day. We start to actually look at patients and what's going on after 24, 48 hours of an indigent patient, because we're normally used to seeing them for that length of time in the ED. So it kind of starts to hit our risk factor in what's going on when they're sitting a little longer than that. So we've kind of gotten used to this long length of stay of those patients now, to where we allow that 24-hour mark, sometimes going into that second day of 48 before we start saying, wait a minute, why is this patient not moving? We're just so used to that length of stay in the ED for that patient. Our patients in our rural areas experience a significantly longer length of stay due to limited available needs and services. So our Atlanta patients actually move pretty quickly, and this is something I talked previously about with the judges. In Atlanta and our surrounding areas of Atlanta, there is a lot of support services for behavioral health. There is a lot of nonprofit. There is a lot of different groups that help out the homeless populations, the uninsured populations. So we tend to see movement a little faster in some of those facilities. But where we really see the issue is sitting in Athens, Columbus, Macon, Augusta. We're going to see these more rural areas where there's less support services to our facilities, and these services, everyone is using these EDs as that space. So even though we do have long length of stays, and we definitely see it due to the larger populations of Atlanta, we tend to see our movement a little bit faster, and we have other groups that help out with those populations. When we go in the outside perimeters, we just don't have those support services. And these patients are coming in from very rural areas where there's absolutely nothing to even discharge them back to. So we know they're coming in, we can treat them, but when they discharge out, there's nowhere for them to go. The length of stay is significantly growing for uninsured patients. It's definitely started through COVID, definitely started through the shutting down of the beds, COVID beds coming offline, as well as our CSBs and our state agencies losing staff members. So we definitely have seen this uninsured patient sitting for much longer lengths of time. And that has really impacted because obviously with COVID, so did our emergency room needs increased. And we're just not seeing a difference at this point. So it went high and it has stayed significantly high for that, that patient in particular. So the impact on our hospitals, that we are now having a very hard time providing adequate safeguards for our at-risk patients due to the nature of the environment and acuity. Holding patients for days of week awaiting a transport presents challenges for acute care patients that are presenting for treatment. There's little to no reimbursement for hospitals with patients for these longest hold times. So for the most part, our patients that are sitting there for the longest wait times are our indigent patients or our Medicaid patients, and there is, that reimbursement is very low to almost non-existent. And then hospitals are often incurring the expense of placement for patients who do not otherwise are accepted for necessary care. So Piedmont, and there are a couple other larger medical facilities at Point that do contract with private facilities to pay for our patients to be taken to inpatient sites. So Piedmont actually pays for a patient to come out of an ED, and we place them in a inpatient psych facility to get that patient moved quickly to the treatment that they need that otherwise no one would take because of the payer source. There's no payer source. So the only way to get them there is for us to pay for it. So we do that at pretty large rates at this point in time. And our behavioral health patients are increasingly violent against staff, resulting in injury and retention issues to our hospital staff. This is just due to, again, long lengths of stay. The patients are really having a very difficult time being there. On top of the fact that we are seeing a much more violent patient coming in, we have become very much that center hub for drop-off. So we're getting patients that back, a couple of years ago, law enforcement most likely would have handled. Now it's become very mental health focused. So they're coming to the ED to avoid bringing them into the legal system. So the ED has become the drop-off for those patients. And so we're seeing a very high, the high volume of violence coming into the emergency rooms. We actually just had a patient that was brought in by law enforcement, a very large patient that did not want to stay there, that did actually attack one of our staff members, resulting in a pretty severe head injury with seizing. So it's definitely something that our hospitals are dealing with as we try to help the patient, keep them safe, but also how are we keeping our staff safe is a big impact for us now. So just talking about the financial impact of the systems, in the past 3 years, Piedmont has experienced an annual average of $18.7 million in uncompensated care relating to our behavioral health patients. We have spent over $3 million last year to place BH patients who are unable to be placed timely in a private facility. We have paid for that bed placement ourselves. We do incur millions a year to holding patients in our emergency rooms. The GCAL process is lengthy and delays ability to claim beds for patients within the days they need, resulting in much longer stays. So not too long ago, or a couple of years ago, the GCAL board worked a little bit smoother. There was a amount of time placed on moving a patient from status to status. Now that status movement is very slow. So they will move to a yellow status where the state hospitals are able to pick up those beds, but it will sit in that status for quite a long amount of time before they move to a green status. A green status gives the availability for all the private entities to pick that patient up off of a contract bed at that point. The length of stay is significantly longer for patients due to inability to find the placement, and our patients have higher acuity or frequent trips to the ED, can remain in the ED for with an unnecessary medical bed for 3 to up to 100 days. So we absolutely are having patients that do hit 100+ days sitting in our emergency rooms or on our medical floor beds. So the private facility contract and bed placement fee, that's just due to the high demand of our behavioral health patients and the slow movement of placement for many of our health systems. to move those patients. We contract with this private healthcare system. We do pay $4,200 per patient to accept a patient that has no insurance, or if it's a patient with a traditional Medicaid, that patient that majority of our private freestanding facilities do not take Medicaid. So those patients, those are the two patients that we are paying for this patient to be moved. And that is directly attributed to the bed capacity and availability for our patients. So the continuum of care, these are some of the things, recommendations and thoughts that I have just had since I've been working in this field for quite a long time, that the behavioral health patient care is widely distributed to different facilities with numerous treatment plans and discharge options. So our behavioral health patients flow into our emergency rooms, and they are literally given the first available bed that's open, and they can spread throughout 20 different facilities. Those 20 different facilities are going to have 20 different medication recommendations, 20 different discharges, treatment plans, 20 different ways that they should have different ways for discharging and treatment planning. So our patients are coming into these facilities, and we're literally trying to get them into an inpatient bed as fast as we can. And really what it is the first available or the second available bed that pops up, or sometimes patients are only getting into one. They're going to move into that available bed as fast as they can. And then we're going to create the situation where there is a lot of different people now involved. We will see patients come into our inpatient units. They're treated, they're stabilized, we are sending them out. And within a month, we will see the patients right back again due to the fact they came to an aftercare provider. That aftercare provider took them off of all of those medications and destabilized them and decided on a different treatment plan route. And now they're back in crisis again, coming back into our facilities. So we see the system has just multiple facilities that handle inpatient, outpatient. Throughout their journey, no one is actually managing the patient's care. We leave it to the patient who, in behavioral health world, that patient has a lot of struggles managing their own care. They don't advocate for themselves very much. They really do fall and listen to the advice of these professionals. They're just getting a lot of professionals with a lot of advice. Outpatient psych service are challenged to provide consistent and stable care. Discharge planners often sending patients to primary care physicians. So it is very hard to get patients step down into psychiatry in different areas of our communities. Psychiatrists are full, they are busy. The majority of them are private pay only, so you can't use your insurance if you want to see them. So for the most part, we are actually discharging our patients to primary care physicians, which are not experts in their field, and they're very uncomfortable with some of the levels of the psych medications that our patients are on. So we definitely see that discharge planners are having to do this just to get them in to see a professional, but at times that's also kind of biting us on the other end. The medications and treatment are altered by the outside treatment facility, causing them to readmit within a couple weeks. Patients also often name multiple treatment teams that they've encountered in a few short months, each changing and altering medications, interventions, and the medical units that are discharging patients. A lot of times, if it's on a medical floor, so when we treat our patients on the medical floors with behavioral health as their main psych issue, because we could not find them a psych bed, those discharge planners do not have the scope of what's going on. They don't know all of the different parts of behavioral health world. They're used to treating and case managing a medical patient back into the medical world. And so this is a real struggle. They have a very hard time finding the correct placements and services for their patients. And there's also the whole aspect, there is not a great system within the state that identifies all the treatment models and treatment programs out there for patients. There's a lot of different models that are used within the state of Georgia, and a lot of wonderful programs, but in case you don't meet that person that does it, it's very hard to know it's even out there, it exists. There's a lot of times in the behavioral health world where I'll go to a continuing education class and meet someone and even me, and it's like, I didn't know this existed. I didn't even know this service was something you did. And then I would find out, that it's a nonprofit, and then, it could be for an indigent patient. These are services that are just not widely known. Everyone's kind of doing their own thing, and they're in these little pockets, but how does everyone in these larger facilities know about it? It's very difficult. So I think there's a lot of different treatment programs and models out there, There's a lot of emerging treatments for behavioral health patients that we are seeing beautiful results. One, those are not going to be covered by insurances. You're not going to get a lot of practitioners that can even afford to do them. But it also is something to really look at, because we do need to stray away from the traditional models that is failing a lot of behavioral health patients. And there are new models out there. So just to look at the different options that are available for behavioral health patients, there's a lot out there. We're just very hard to get into those models. So recommendations, increase in patient bed availability. Obviously, I know that's something everyone's talking about. Patients have little to no options when choosing behavioral health facilities if they are not commercially insured. So our commercially insured patients absolutely can get a option, and they know where they want to go and they can go there. They get that choice. But for the most part of our other patients, that is not an option. There's maybe one place that will take them, so they go to that place. Most patients are transferred to wherever accepts them, regardless of the ability to meet that patient's need. So at times you'll see a patient that goes back to the same facility over and over and over again. They haven't met that patient's need the first 3 times. They're not going to meet it the 4th time. The private facilities are rarely at capacity, but they're unwilling to accept the patients due to payer issues. So we do see and do know the majority of our freestanding private facilities are not at capacity on a daily basis. They have beds that are available and open, but the majority of patients that are waiting to have those beds are non-insured patients, so they will not accept them due to payer issues. Providing alternative treatment for a larger acceptance criteria. This is something everyone is battling with in every medical facility. Is that patient that has hit medical exemption, like they're exempt from the psychiatric treatment facilities. Easy things like oxygen, catheters, a woman that is pregnant and in a certain term, they are automatically excluded from mental health facilities. Those are medical criteria that we do not move patients into, and it is increasingly becoming a large number of behavioral health patients at this point. They are rarely treated at the level and need for the developing routine medical conditions that are coming. And most acute care hospitals do not have access to the psych services for the ongoing treatment of our medical patients. So within the system, we are constantly trying to build and bring in the psych care that is needed because we are just seeing that our medical floors are going to have to treat these patients. We are constantly looking at the fact that this is the cost that we will have to take on because our patients will have nowhere to go. So they can't sit in the emergency rooms. They are moving to our medical beds, but now we're going to see the issue where they're now taking up our medical beds, and they will stay for greater lengths of time than what a medical bed is usually held at. So as they sit there for 7 to 10 days, those medical beds usually can be released after 3 days, and we're going to start to see a backup of the medical beds that are existing within the state. And so our psych EDs and our emergency receiving across the state with the ability for medical clearance, therapeutic treatment focused centers for behavioral health patients should be looked at for present to be dropped off by EMS or law enforcement. There was a model that I worked at out of Tallahassee where we did have a central receiving facility for behavioral health. And that was the patients that were brought in from EMS. They were brought in from the law enforcement. They were able to be dropped off and brought in by family and walk-ins. There was an actual center that was situated within Tallahassee that this is where they all went to. There was medical clearance that was able to be done there. The patients were all, were able to be brought into different areas of that setting in a very therapeutic environment for what was needed. And those patients were not hitting the emergency rooms at that point. The medical clearance was able to be done there, which helps relieve the issue to why a lot of our patients are coming in for that medical clearance. And then that can help support the expansion of DBHDD's behavioral crisis centers, their crisis service centers, to provide the alternative treatments to hospital placement. And that is all I have. So is there any thoughts, questions that you all have for me?
Fiona, what do you think about the idea of potentially having a behavioral health crisis center or crisis stabilization unit somehow connected to the development of what I would call modern jail? Because it seems like police officers have a lot of discretion out there on the street as to whether to charge or not charge, and then they have to make a decision about what to do with the person that they encounter. Do you see any value in maybe a DB and local jails type of partnership where you have these two types of services kind of joined together?
Yeah, so the real issue with the patients that are being brought in by law enforcement is that they are already so far into crisis that the police have been called, that they tend to be your highly acute patients that are very violent. Those patients have hit that level where nobody else can control them and they're calling the police, right? So that is a very high level of patient. And when they're brought in through the emergency rooms, or they're brought even into a psych center, that patient is very difficult to manage for the regular staff population. I would say that. So looking at whether there is a way for this population to move into a therapeutic setting that is still attached to law enforcement is actually something that's very valuable, because the patient at that point is going to be so out of control that it's going to be extremely difficult, even if you administer medications, which is what is always done. That's very traumatic for patients, and it's very traumatic for staff to go through it. I mean, sometimes, when you are trying to physically restrain a patient, it's very traumatic for everybody involved to do it. It's not something anybody likes to do. So having an actual situation set up just for that patient, I think is important, because when you have those specialties, you really can look at what that specialty should clinically look like. There's a lot of ways that you can make areas safe, and there's a lot of ways you can do different things, but you can't do it all in one place. So if you're looking at something like an emergency or an aura intake setting at a freestanding psych facility, they're not built for the patients that's coming in and throwing furniture. They're not built for any of that. And so knowing that this patient is coming in, they're already at this level, and they would have a special space that they could go into that, it could just be a room that they're okay. There's nothing in there dangerous. They're going to allow them to exhaust their energy. They're going to allow them to kind of get to the point where they're not feeling contained and things like that. I mean, I just think there's maybe a lot of more clinical options to deal with a patient at that level than where we're at now, where those patients are so dangerous, and they're dangerous to themselves. I mean, we definitely worry about our staff, but we worry about that patient too, because when they're out of control, they can easily be harmed. And we want to try to figure out the best way for that not to happen.
Okay. Also, I have a question about the type of information you have available to you at the time that you first have intake with these patients. Do you have extensive medical histories typically? Do you have access to psychiatric directives?
No. So, majority of when our patients come in, unless they were part of Piedmont previously, so a lot of our patients that come in frequently, we know about them because we've gathered a lot of information over the previous times they've been there. So we know a lot about them. We do contact family as much available for any kind of family collateral. So we do try to gain that whenever we can get it, to find out what a lot of their historical issues are or what that baseline looks like. But there are many times we are just literally have to take the patient at face value, whatever they're telling us. And we have to go by what that is, because a lot of times, and I will be honest, behavioral health patients that are in crisis are not good at giving out that information. They're confused, they're unfocused, they give us very unreal information. I can't tell you how many patients that we accept as indigent patients onto an inpatient floor, and then within a day or two of psychiatric medications, they are actually, I have Aetna, I have this insurance. I mean, they were so confused and unfocused when they came in. They didn't even know that they had insurance, right? But after you give them treatment, they now know, and they can give you a lot more. But really, the admission part is we ensure that we have qualified licensed therapists and behavioral health support that is working all of those assessments, just to be able to have someone that's as knowledgeable as we can be to get as much information as we can.
All right. And does anyone else have any questions? Dr. White, Dr. Bailey, Nora?
have additional comments to add on to what has been stated thus far. I think that some of the previous conversation that we had was about kind of making sure we do this diversion from the criminal system to the hospital system to make sure they receive the mental health care. And we were hearing about some of these disparities within the hospital environment as far as various staffing, also the mental health access to various inpatient and also outpatient that's causing a bigger strain on the overall mental health treatment community overall. And so make sure we need to put an emphasis on that. A couple of subpopulations that I want to make sure that we are looking at also within the emergency departments that come in with various behavioral health conditions or issues are those that have developmental delay. That has been an uptick, especially within our hospital environment, and we do not have the resources that are out there in order to assist them within the community. And many hospitals deny them based on this pre-existing developmental delay that they have. And so that, and also various people with substance use disorders and the resources out there, especially for those that do not have insurance, do not have resources or kind of community out there, that's very lacking and cause increased number of visits to the emergency department on a regular basis. And so just want to make sure that we state that. And although it's great that Piedmont has those resources to kind of get them in the Atlanta area, it looks like we're seeing almost about 10 times the amount of patients within the Atlanta area within our emergency department. And we do not have those resources available for that vast amount of population that is in need of various routine services, such as getting to see a psychiatrist. It takes a significantly long time in order to access those resources. And with the police that are bringing them in, we've anecdotally seen a large range of patient types, whether they are kind of more reserved and isolated and coming in by police because we do not have EMS, emergency medical services, in order to bring them into the hospital. And so police are charged with that to bring them into the hospital at whatever state they're in. And so it would definitely be helpful to have increased number of engagement of mental health professionals within the community to be able to access some of these various patients to make sure that they have those services that they need.
Anybody else? Karen, Nora? Just a couple of quick follow-up questions. You mentioned Tallahassee as being a place, Fiona, where they're doing things perhaps a bit better in this space. Do you happen to have any additional information you can share about the nature of that facility? In other words, you know, what is it? Is it through the Department of Behavioral Health in Florida that they're paying for that service? And that
so it was actually a collaboration between the behavioral health state or the Tallahassee Psychiatric Center for the state. So it was actually Tallahassee's freestanding mental health facility that had the campus, and they did have a space that they had seen the need for alleviating the emergency rooms within Tallahassee from behavioral health. So when I started working over with that, with the North Florida region, we were seeing a large increase of behavioral health patients into the emergency rooms with the same issues that we're seeing now. You know, Dr. White has said, there's many facilities that do not have psychiatric services to handle these patients. It's very hard to get psychiatrists on board to see these patients at these rates. So there's just so many patients that are in medical facilities where these medical doctors are not equipped or know how to handle that, right? So what we're looking at now is within Tallahassee was that they made a central space. Now Tallahassee is not Georgia, but it was a place where the hospitals all were part of this coalition to make sure that we were all on board with working with this agency. So the state did fund this and employed it, but we were all at a table every month that we worked with. What are some of the different things we can assist with? How do we support it? The facilities that I were working with did have inpatient psych. So we were definitely part of the case management monthly basis to talk about where the patients are going, ensuring that we're helping and opening up our psych beds and working with that system. As a collaborative effort between all of the behavioral health systems, we all work together to ensure that that entity stayed completely flowing, that there was not a lot holding it up. Everybody definitely came to the table to help ensure that it was working properly. but it was also a really great place for one group of people to know what was going on. Everybody was flowing through there. The assessments were coming out. The staffing knew the patients. Again, it's coming from one area, but if you look at that as a broader, way, there was different entry points. So EMS would enter if there was more of a medical issue situation. We definitely had the police and law enforcement entry area that was very different. They went through a much more secure area, but we were able to really push that population into different groups and have them have different entry points in different waiting rooms so that they were not all compound on top of each other and kind of triggering each other as they worked through that. So it's definitely quite a setup, but it did take all of the psych facilities to come to the table to help keep it moving. And what I find right now is all the psych facilities work very siloed. Everyone is really looking out for themselves and looking out for that population. And at times that's where we start to see these patients just, they're flowing everywhere. They're literally flowing everywhere. I could get on a call with many psychiatric facilities and other EDs, and we'll talk about the patient. Everyone knows them. DBHD knows them, right? So at the end of the day, we're all touching these same patients, but not one person has any kind of, no one's actually watching this patient. We don't know where they're going.
Fiona, would it be helpful to know how this person flows through the system?
I think it would be very helpful to know where, I think what we would see is with the majority of patients, they're not really flowing through any system. They're constantly going into crisis services. What we love to see is when the DBHCD is actually case managing a patient. That's the most wonderful experience. We have this very highly down in Macon. When we get a patient in the ED that we know is actually part of the River Edge system down there, we call River Edge. They come, they help us case manage the patient, they tell us a treatment plan, and they usually end up taking the patient out with them and bringing them to treatment where they need to go. That's a really smooth situation. I don't see that in our other facilities as much, but that's something that we have worked very hard with River Edge and Macon to do. Knowing that this population doesn't always need inpatient care, they know this patient doesn't need inpatient care, but unless we're offering this patient another resource, we're not going to see them leave. They're not going to have any other movement. So it's important to really know where they're coming from and what's going on, because it helps us create the situation, and there has to be more options we offer these patients, I will say that.
More options, but you said there are a lot of options that are out there that you just don't know about them as part of the discharge planning. That's true too?
Yeah, there'll be a lot. There are a lot of options that are available to patients that majority of people do not know about. So even like I talked about River Edge being able to come in and maneuver our patients out of the ED and take them because they're already working a treatment plan with them. That's the only facility that Piedmont knew about doing that. So that's something that, as coming in, I've started to set up with Viewpoint Health with Rockdale, and it's an option, but no one knew it was out there to do it.
So maybe there needs to be some kind of an effort to collect all of these options and provide them to discharge planners throughout.
Yes.
Okay, anybody else? Well, that, Fiona, was excellent and very, very informative. We really appreciate you and all the work that you're doing and your commitment to this space for so many years. I don't have anything else. I just have to absorb it and to try to see how we can best help you. There is an organization of psychiatric providers that I think Dr. White attended once. That's in Atlanta, is that right? And you're kind of working through this problem as an organization of private entities? Fiona, is that right? Or is that Sarah Moses' question?
We work with Archie in the collaboration. It is Piedmont, Northside, Grady, Wellstar, CHOA, Emory. We are all coming to a biweekly call. And it's really all the behavioral health and DDD people that are really handling that for all of our hospital systems. And we do bring DBHCD in once a month, people working with the GCAL board. And we're really just trying to plug through the issues that we're all seeing and trying to find ways to, as a collaborative group, as I said, we're all having the same issues. I think for Piedmont, we have it as a large issue. So when everyone comes to a table, they have a small population they're dealing with because of their 1 to 2 facilities. I've got 19. So mine is always compacted, and then I'm in these very rural areas where there's nothing. So RED is the treatment facility for a lot of our rural hospital, or a lot of our patients, and everybody comes there because they don't know what else to do. So with that, I think I'm compacted a little bit more.
When you talk about Archie, is there something about that organization that can inform the work that we're doing? Is there a way that you can report out to us any recommendations that you have as to how to improve DBHDD's interaction with you and all of the Archie members?
Yeah, I mean, we definitely have started to work a lot with DBHDD. We have set up every system has actually set up a biweekly meeting with developmentally delayed group of DBHD, which has been wonderful. So they've been extremely responsive with the DD population and the crisis that we're in, to where every system pretty much has a weekly phone call with DBHDD with the DD side, their regional director and their divisional directors, to try to move these patients as quickly as we can through the system. We're trying to set that up right now with the mental health side, as we don't have any connection at that point with there, but we're trying to work on that piece right now.
Well, we're trying to support you in this space. And so if you could think of any recommendations that we need to make to the legislature to do that, then I hope that you will contact us, any of us, and we'll find a way to vet it then and perhaps have it included in recommendations. So thank you so much again. And if there's nothing else, many of the committee members, no other questions, then I believe that's where we are. We're finished for the purposes of today with your presentation. Thanks again.
Thank you all.
And any final closing remarks by anybody? Okay, well, hearing none, thanks everybody for attending today. Really appreciate